Okay, let's begin. Uh, right, right now, we'll discuss next clinical case. Case number 2, this one, this one, this one. 56-year-old man. Oh, I'm sorry.
So we can see.
Share. I forgot the sharing. Share screen.
Sir, start the recording also. Thank you, sir.
Yeah. I'm recording. So, can you see this? Yes, this clinical case. Yes.
Yes, sir. Yes, sir.
Yes. Good. Very good. A 56-year-old man attended to the renal outpatient clinic because of polycystic kidneys. Polycystic is a formation of follicles inside of kidneys, which had been diagnosed 20 years previously. 20 years is a very long period, so this is a chronic disease. So for a long time, not acute disease, like in previous case. We see road traffic accidents. It's a very fast situation, the very acute situation. But here we see a long distance situation. There's a chronic situation. He was hypertensive, and the following blood results were returned. So here I want to show you that this to give you some information about regulation of um, blood pressure by kidneys. So we see hypertensive patient. So that means that this patient has high blood pressure. Why we have to keep in mind this fact? Let's look at the mechanism of filtration. Wait a second. Filtration. Glomerular filtration is a process of the transport of components of blood from afferent arteriole into proximal tubule over here, from here to here, into proximal tubule. So the mechanism and some part of blood transported after that by afferent arteriole over here. Some percentage of some part of blood filtered into proximal tubule. To do this work, glomerulus should regulate diameter of afferent arteriole. It uses specific regulation mechanism. Over here, there is a specific part of nephron here. The first one is macula densa, or density spot over here. Macula densa is in Latin, and juxtaglomerular cells over here. And the juxtaglomerular cells produce a specific enzyme, renin, which converts angiotensinogen into angiotensinogen 1, angiotensin 1. And after that, it converted into angiotensin 3 or 2. And after that, in case of accumulation of this agent, the blood pressure in this patient could be high and then in healthy people, higher. So in case of problems, in case of inflammation or different problems, other problems with glomerulus, in most patients we see high pressure. These patients are become hypertensive. What we see, so again, we see in this patient, polycystic kidneys is damage of kidneys. This damage is chronic damage because of 20 years of this situation was found 20 years ago. And this patient is hypertensive with high blood pressure. Let's look at the results of biochemical test. We see sodium concentration is almost normal, but low, it's close to the lowest concentration which we can find in healthy people. Potassium concentration is higher than in healthy people, than the highest concentration of healthy people. The same idea, the same situation, 6.1, and here we see 6.2 compared with their healthy reference range. Concentration of urea, again, we see approximately more than 3 times more than concentration of urea is higher than which we can find in healthy people. We see urea considered 24 and the highest normal concentration 7. Creatinine concentration 360. It's approximately more than 3 times higher than in healthy people. Estimated glomerular filtration rate 14 milliliters per minute. Albumin concentration lower than a normal range. Yeah. Concentration of calcium problems. Regulation of phosphate higher than in healthy people. And we see again the sign of acidosis is a lower concentration of bicarbonates. So what we can conclude in this patient? So this patient has a chronic disease of kidneys. So we can suppose that their kidneys of this patient were damaged. And now we have to how can we which clinical factors or facts or I'm sorry, who is it? Dipanshu. So we can conclude that these changes of concentration of potassium, urea the main, and creatinine are the main, which main signs that can give us information about the damage, the rate of damage of kidneys in these patients. Let's look at their table. We see concentration of serum creatinine more than 3 times than the highest normal concentration. So we can conclude that this patient has kidney failure stage. That's it. So this is a conclusion for this clinical case. Let's look at the next. So if you have any questions, you may ask me right now, or if you
in conclusion, we just have to write stages, right?
Yeah. You have
Stages
to write two points. The first one is what happened with this patient. So we see in first case we see acute damage of kidneys. This is the first point. The second, you have to find a stage. You have to estimate the stage of damage of kidneys. That's it. So in first case we see a risk stage damage. It's acute damage of kidneys. Risk stage because of concentration of creatinine. It's approximately 1.7. It's more than 1.5, but lesser than 2.0. So it's a risk factor, risk stage of damage. But the second stage, this second case, we see chronic. It's chronic. It's a long damage. So in the first case, we see acute damage during road traffic accident. But here we see, in this case, we see 20 years previously diagnosed pathological disease, pathological state. So at the same, so we conclude, we see acute, or first case, we see acute damage of kidneys, but here we see chronic.
Second is chronic.
Chronic, that's right. So the second question which you have to answer is is a
Stages.
stage of damage. Why we have to do this conclusion according to the stage damage, state damage, because in different stages we have to give these patients different treatment. In most cases, the first situation doesn't need any complex solutions, but here in chronic disease there must be kidneys transplantation. It's very possible in these patients because is a kidney failure, is a very late stage of damage. So these are the first one, damage or not, chronic or not, or acute. And the second one is a stage of damage. Let's look at the next case. I think the last case. They are very similar, so they are very simple cases. Case number 3. 21-year-old man presented to the urology outpatient clinic because of renal calculi. Calculi is stones in kidneys here. There was also a family history of renal calculi. So her parents or maybe some relatives of this patient suffered from very similar or the same disease, a formation of stones in the kidneys. Let's look at the biochemical results. So at first we have keep in mind that this patient has complicated history. So it has relatives with the very similar or the same disease, formation of stones in the kidneys. Let's look at the biochemical tests. Sodium, normal. Potassium, normal. Urea, normal. Creatinine, normal. Estimate, it's a normal. Albumin-adjusted calcium, normal. Phosphates, normal. Bicarbonates, normal. Urate, normal. So what is it? So you maybe know that the renal stones could be formed from different components. We know that in some cases protein calculi build of urate, phosphate stones, calcium stones. So, but here, concentration of these components are in normal ranges, in reference ranges, like we can find in healthy people. I could look at the last 2 sentences. This one. Urinary excretion of both calcium and oxalate stones. I forget. Oxalate calcium or oxalate fell within the laboratory reference range. So oxalate stones. Let's look. What is it? So oxalate stones. Oh, here. Maybe we can find this. Oxalate stones. These are like these, different types of oxalate stones. But we see, however, cysteine was detected in urine. What is cysteine? Cysteine is an amino acid. Cysteine is an amino acid which build of 2 cysteines, 2 residues of amino acid cysteine. The first one, cysteine, and the second one, cysteine. And when this chemical produced an excess of production, and when we see excess of production of cysteine in patients, cysteine could be converted in, could be as can be used as a substrate for formation of cysteine calculi, cysteine stones. Cysteine stones. Let's look. What is it? These are, yeah, this one, cystine kidney stone. So we see. So what we see in this clinical case, we see this patient has a family history which is related with renal calculi in his relatives, renal calculi. So his relatives suffered from renal calculus. This man is very young, 20, for formation of stones. In most cases, stones in the kidneys produced in more older age, older people, because of problems with their kidneys, inflammation in kidneys. But here we see 22-year-old man with who has relatives with renal kidneys. All biochemical tests are in reference range, but we see cystine was detected in urine. So we can suppose that this renal calculi is induced by accumulation of cystine in the urine. So this is the answer for this question, for this clinical case. So what we can to say, what happened with this patient? We can say that this patient suffered from renal calculi because of genetic disease, cystinuria. Let's look, what is it? Cystinuria. This is this situation. Cystinuria is an inherited autosomal recessive disease characterized by high concentration of amino acid cysteine in the urine, leading to the formation of cystine stones in the kidneys, ureters, and bladder. So this is a genetic disease which we found in this patient. Other clinical cases, cystatin, Health African American Emergency Department, nausea, 4 days, creatinine. So again, when you answer for the question, you have to for making a conclusion, you have to explain what happened to these patients. Here we see formation of cystine stones. Here we see acute damage, and we can write a specific stage of damage of kidneys. Here we see acute damage of kidneys, and we have to write stage of damage. So how many problems? Let's look. 11. So we discussed 3 of 11 clinical cases. I think it's enough to understand all clinical cases. So at first you have to read the theory. After that, answer for theory questions and computer-based test. And after that, during the next 2 weeks, please do this conclusion for to write the conclusion on clinical cases. Okay, thank you. If you have any questions, you can ask me right now. Or if
Thank you, sir.
Bye.
Sir.
Yeah.
Sir, with mini video. Sir.
What again?
Recording, sir. This recording.
Yeah. I'm recording. I upload this record on Moodle on the appropriate part. Okay.
Okay, sure.
Sir.
Okay, sir. Okay.
Thank you.
Thank you very much.